You're listening to the Toe Talks podcast.
You introduce fear and hunger into a population of people, and then you control the information to assuage the fear, and you control the food sources to alleviate their hunger. Then you have the control. I mean, there were a lot of forces at play that took the practice of medicine out of physicians' hands. I don't think that it's within your purview to walk into my hospital where we have bylaws and policies and procedures approved by our medical staff and try to tell us how to practice. That has never happened in the history of medicine. It's not going to start here today. You must take the vaccine. I beg to differ because we know that we've been exposed to this in the emergency room now for months. We have been vaccinated with a live virus. How about we do titers and see where everybody is? Doesn't matter what your titer is. You must take the vaccine. So that immediately became a red flag. The volume of patients became biblical at times that we had to deal with. I don't know another vernacular to use. We had patients that would call from hospitals as far as 150 miles away and ask if they could be transferred.
What were your thoughts on masking?
It was ludicrous. The whole thing was ludicrous.
What would you say to me if I told you there was a U.S. hospital during COVID that had doctors who treated patients early, prescribed ivermectin, never used remdesivir, never used ventilators for COVID patients, did not wear masks, weren't COVID injected, and as a result had zero loss of life due to COVID infections? Hold on to your lug nuts. We are about to embark on the naked truth about the dark reality of the pandemic, as there could have been a very different outcome. We are the rugged, authentic savvy, and you're in the right place. Live free. Pursue health. Powerful living starts in 3, 2, 1. Welcome to episode 17 of the Toe Talks podcast, the doctor who did the impossible. I'm your host, Dr. Toe. Have you ever wondered what the pandemic would have looked like if ivermectin and HCQ had not been vilified and the COVID shots had never been given EUA status by the FDA? Well, you're about to find out, and you won't be surprised at the outcome, but you may be very angry, and for good reason. Today, I interview a very smart, well-seasoned physician who won the war on COVID. He and others like him at this very particular hospital saved every single life that walked in as they all walked out. Please like and subscribe to the podcast as it helps to grow the podcast so that others can hear the truth. But more importantly, share. Please share this podcast and its information with others. And now, part 2 of the Toe Talks podcast, the doctor who did the impossible and won the war on COVID. As a healthcare worker, I'm always curious when I meet other people that are like-minded, especially during that time period. Did you feel like you were going insane and the world was sane? Because your thought process at that point in time was very foreign. It was very unique. It was not the norm, at least as the mainstream media would want you to think.
I did not feel like I was insane then or now. There are probably people that would argue that point, but I did not. Once again, I was very fortunate to be in a small cohort of other physicians that were like-minded. So had I been on an island by myself in that situation, I'm sure the pressures would have been different. I fortunately was not. I didn't have to battle any of those external, except for that one visit from a state person. We didn't directly have to battle any of that pressure, I guess.
But you know, and see, that's the beauty of that too. There's a lesson in that as well, that you had other people to support you.
Yeah.
You were a formidable force. So when the state person showed up, it wasn't just you. It was you and many other people in your hospital. I
think that that's part of what they saw, too. It's like, well, this isn't one or two quote-unquote rogue doctors who are off the reservation. It's like, oh, there's a whole community here that if we start swinging an axe, we're going to cut down all the trees and
yes,
we're going to have a problem. So
yeah,
they left us alone. It was a strange time for sure. I never felt like that. It was tiring for sure. Emotionally, physically, mentally, spiritually, it was a very tiring time.
Yeah,
very,
because
very tiring
you were
time.
always constantly having to weigh what was good, what was true, what was
There's just a
best.
lot of the volume of patients became biblical at times that we had to deal with. I don't know another vernacular to use. It was just a lot more than our system was used to dealing with.
And I kind of wonder if that's because word got around about your success that all of a sudden, because if I was living anywhere close to you with where my mindset was, and I had heard what was going on in your hospital, I'd make an hour trip.
We had patients that would call from hospitals as far as 150 miles away and ask if they could be transferred to our facility. And if we had the capacity, the hospital has taken those people as they could. We had to create a COVID ward that was mandated, but the whole reverse isolation thing. And so the hospital, fortunately, invested in the money in that very quickly, and we're able to bring that online. So I think at the peak of things, we might have had 20 beds that could be in negative pressure rooms, which was a lot for our size of facility. But they stayed full all the time because people were asking to come there.
Yeah, I would have been one of them.
Yeah, it was good. I mean, our outcomes were good. So
Right.
The situation was not good at all, but we were able to help people.
That's where you go. You want to go to the best place possible. It's just like school with your kids, you want to send them to the best school.
We collected a lot of data along the way, too, because we intended on publishing.
Yes.
And then we're told, we're not going to do that.
Oh, see, and that needs to happen.
A lot of things woulda, shoulda, coulda.
Yeah. Again, it's too much truth. You can't handle the truth. You know what I mean?
There's a lot of that out there.
What were your thoughts on masking?
Oh, my gosh.
Is this a loaded question?
So it was ludicrous. The whole thing was ludicrous to me. First of all, by the time they named the virus, it had probably been in the United States conservatively, and we know this more factually now, since as far back as October, had not really become in full bloom probably until late December, early January, and the rest of that's history. Number one, it wasn't like this was a brand new thing. It's like, okay, we're going to create isolation. Number two, the size of the virus, we knew, because it was a coronavirus, and we measure those things in angstroms and microns, very, very small particles. So we knew the size, the exact size. If you're going to use a mask to contain something, then that mask has to be able to filter that particle. The only masks out there, the only over-the-counter mask that would do that would have been an N95 type mask. There weren't enough N95, as you know, if you were around, if you went and tried to buy an N95 mask, they didn't exist.
Yeah.
So then because that was the mandate.
That's because
that
China
was part of the
bought
mandate.
them all up.
Must use N95 masks. Now all of a sudden there were no N95 masks because the supply got depleted.
China did
Well,
that.
if you can't get an N95 mask, just use any mask. Well, that doesn't wash. Okay. The surgical masks. Well, we'll use surgical masks. They're good enough for surgery. Okay. Well, why do we wear masks in surgery?
Exactly.
They're not to protect us from the patient. It's to keep us literally from spitting and coughing
Bacteria
into an open. It's a barrier for large particles.
Exactly.
Large particles. Okay. No gross contamination. There are places in the world, I will tell you, that they don't wear masks in the OR.
Oh, yes.
I have been there to some of them. They don't wear masks in the OR because that overall effective. Not saying we shouldn't do that. We should wear masks in the OR.
Sure.
But to say that a common surgical mask was equivalent of using an N95 was silly. And then it came out with everybody had an Etsy page, was making designer masks out of cotton.
Cloth.
That
masks.
was making, out of cotton and stuff like that. Well, that becomes even more silly from a scientific standpoint. And then it was just like what any mask will do. Just put something over your face.
And it also became a health hazard in
Yeah,
many ways. Because now we're talking about textiles.
Yeah.
And this isn't even, overseen by the FDA, these cloth masks.
Nope.
So,
Nope. Well, nothing was out. I mean,
yes.
N95s that you go over, they were not, those are not FDA approved. It's just an N95 mask because industry has used N95 masks for general industry. Anybody that produces any kind of particulate matter, N95 has been the go-to for eons.
Yes.
And so they were very commonly in place. They were not a medical device by any stretch of the imagination, not a medical device. They just knew that was a ready-made thing that would filter that size of particle. So therefore, that's what we'll recommend. Okay.
But even that was not foolproof because your mask gaps one time the virons in.
So the only way, especially in a viral type respiratory spread, droplet spread, the only way to be assured that you're not going to do that is to be in a PAPR type, a positive pressure type system where it pushes everything else out and you get nothing but filtered clean air in. And there were people wearing PAPRs.
Yeah.
In some places we couldn't afford that stuff. We didn't have them.
No. Well, you'd have to walk around with a completely sealed.
Those are the people you saw. If for people who are like, what's a PAPR? Those are the pictures you saw people look like were dressed up to go to the moon.
Yes.
So they had on full bunny suits, I call them, from head to toe, and they had on this big face mask, and you couldn't see the PAPR, but it hangs down your back, and it's basically a self-contained breathing, but not like scuba. It's a filter. It filters the air, and it circulates it around your face. So
whatever you breathe in stays in. Whatever you breathe out stays stays in.
So if you want to get right down to it, those were the only foolproof things.
Yep.
And so there weren't enough of those to go around. So then it became, well, if you can't do that, just do the next best thing. Well, the next best thing doesn't work in medicine. I mean, it either works or it doesn't.
Well, and I would give people, I'm looking right now where you have a Coke can on the table over there. And I would give people this analogy. I say, if you were to grab all the COVID viral particles in the world, you could fit them in a Coke can.
Yeah, they're tiny.
So even an N95 mask, I would beg to differ that the holes are big enough that the virus could get through that. When I was working in the hospital, we wore N95 masks for, people who had TB,
right.
Bacterial infections, MRSA, those things, like you said, those particles are huge and they can't, that mask would be beneficial for a short period of time. And this was the other thing about masks that drove me nuts is that people would wear those masks for months. And I'm talking the blue ones, they would put them on their dashboard.
But that evolved over time too because of supply and demand. So it was like, hey, we'd run out of masks. Okay, well, let's come up with a new protocol that says you can wear a cloth surgical mask or a cotton-based surgical mask as long as you put it in a brown bag. This was the funniest thing.
Oh, I hadn't heard
So you had
this.
a little brown lunch bag. So what you did was after your shift, you took your mask, you put it in one of these brown bags and wrote your name on it and then put it over there to the side. When you came back to work, you took your mask out of your brown bag and that brown bag helped. There was all kinds of silliness going on. And we were just like, yeah, that was one of the silly things that went along for a while.
Well, and here's the crazy thing is a lot of people don't know this. And I actually got in an argument when I was in a doctor's office when COVID was at its height because I was like, hey, I'm asymptomatic. I don't want to put on a mask. I have to put on a mask. It's against, US code 21360-BBB. I get to tell you whether I want to put on this mask or not because it's under EUA. And it's still, all those masks are under emergency use authorization. None of them have been approved, even to this day.
Nope, because they don't work. The only thing for sure,
They're
the only
experimental.
thing for sure is positive pressure, some type of positive pressure, a PAPR type system, a closed PAPR type system. And there aren't enough of those to go around. Well, it's impractical.
It even said it on the box. Does not prevent viral transmission.
Correct. Correct.
That drove me nuts too.
100%.
So, in my opinion, I think there are more health hazards.
So it made the whole thing. So once
them.
again, viruses have half-lives. We knew what the half-life was. There's all this research that's been done forever about if you cough, how far do your particles go before they fall to the ground? And all that was known. So that's where the 6-foot rule came up. That's we'll stay 6 feet away from people. It's like, what? Okay. What are you talking about?
Whenever somebody talked to me about that, I would say, you know where that rule came from? And they're like, no. And I said, it came because they pulled it out of their butt.
Yeah.
There's no research attached to that at all.
No, it came out of the average. If you cough, the average dispersal pattern is about 3.5 feet average. It's like, well, we'll just double that. And we keep everybody away. Then if you cough, then you're twice as far. And so you won't cough on the next person. That's where that came. It was totally made up. Completely made up.
It was. They even admitted that they made it up. Okay.
Totally
but here's the other thing. This is why I knew they pulled it out of their butt, because I actually looked at research too. And we're not talking about coughing. We're not talking about talking. We're not talking about singing. We're not talking about yelling. We're talking about quiet breathing. If you quiet breathe, particles coming out of your mouth can float in the air for hours. Mm-hmm. Hours. Now, you tell me how far that particle is going to float.
That whole thing made no sense. When we were just like, oh my gosh.
Yeah.
I mean, it made no sense.
And people were exercising outside with them on. I was working at a military college.
My favorite thing was driving around seeing people in a car by themselves with a mask on.
It still happens.
I was kind of like, are you kidding me?
Do you know, I was walking around my neighborhood recently and saw 2 individuals sitting out on their driveway talking to each other, social distanced, with masks on. This was like 3 weeks ago. And I'm like, oh my gosh, what have we done to people? But I was seeing these young college people run around running with a mask on.
Good altitude training.
Oh my gosh.
They were definitely building up their RBC, their MCV.
I had to
Hey, some
contact
people pay a lot of money for altitude training masks. They were getting it for 35 cents. So.
Right. All right. So next question. Let's talk about COVID testing. What were your thoughts on that when that came out?
So there's molecular testing, which has a pretty high specificity to it. It's not 100%, pretty specific. And then there's antigen testing, which is 100% sensitive, but very, very low sensitivity. I'm sorry, very high sensitivity, very low specificity for a particular virus.
Meaning
strain.
You get lots of high false positives.
False positives. So the antigen test, the rapid antigen test, which you still buy today, those are the ones that you buy over the counter, and were widely being used early on because they were quick and easy to make, have a very, very high false positive rate, very high. And so what would happen is, in my experience, people would take these tests at home. They would test positive, completely asymptomatic, but they just want to know. So they would come to the emergency room and ask for a COVID test. And we were kind of like, you're not symptomatic. We'd prefer not to do that.
Yep.
But some people insisted, so we did. And we did PCR-based testing, which is molecular. So the difference being an antigen test was for coronavirus. That's the sensitivity. So coronaviruses in general. There are probably thousands of strains of coronavirus. I don't know how many, but there's a lot of coronaviruses out there. That's harbinger for the common cold. We've known about it forever. Coronavirus happened to be the virus that the Wuhan lab picked up to weaponize. The rest of that's history now because it's around, it's very common, it's easy to manipulate. So the antigen tests are checking for antigens to coronavirus, 100% sensitive. So if you have any antigens to any coronavirus in your body, it's probably going to turn positive.
Positive, yeah.
But the specificity for SARS-CoV-2 was almost nil because the test wasn't engineered specifically for that strain. So then you turn around and do molecular testing, which was engineered to look specifically for certain strains. So we would do a PCR test on them, and a lot of them were negative when we were doing them. Then people would get upset, but my home test positive, so I'd have to have this whole discussion I just illustrated. And they were like, oh, why didn't they tell us that? Because they don't. The difference is when we had a PCR positive test, now that's not to say that you cannot have false positives with PCR, but they are few and far between compared to antigen testing. So if you were positive on PCR, you were considered positive and quote unquote treated accordingly. And I don't mean that in the absolute sense of giving any medications, but you were given the precautions. So that was the dichotomy in testing that we dealt with.
The person that invented that test, the PCR test, said himself, this is not to diagnose anything. It's actually to tell you how much of what you have.
Right.
So
it's a quantitative test.
So honestly, I would tell people I'm asymptomatic. For you to require me to be tested is really medical malpractice.
Okay, I see what you're saying. That's a whole different discussion. I thought you were just asking me about the two types of tests. Yeah, the whole mandate for testing and we'll test you. I mean, there were places that were like, if you're going to come to work, then you have to be tested every 4 days. Okay, well, where'd that come from? And if you're positive, if you turn positive on, you have 3 negative tests, but then one of them's positive, you got to go home for 2 weeks and all this crazy stuff that made absolutely no sense whatsoever, none whatsoever. And those are all antigen tests, by the way. Those were not being done on PCR, the vast majority. So it was like, well, if you got a cold somewhere in the cycle, you're probably going to pop positive on an antigen test. So, yeah, there were a lot of bad decisions being made. And frankly, I think just silliness being applied. And it was random. A lot of that was being done totally random by institutionally with no kind of guidelines from anybody. Because, well, there were no guidelines because nobody knew what to do.
Right.
So people were like, well, we're going to do it this way.
Yeah.
It
was the wild, wild west.
There are many axioms in medicine. Another one is be careful what you test for. You might find something.
Oh, yeah.
That you didn't intend to find. And then now you're left with, well, what do we do with this, if anything? So that was going on in nursing homes.
Yes. Well, they were running the tests at too high of rates, which would increase the false positive rate.
Correct. I mean, so.
And I think that was on
nursing
purpose.
homes, some nursing homes were testing their residents once a week. Like, why are you doing that if they're asymptomatic? Well, we just want to know. Well, know what?
Right.
And then, heaven forbid, one of those tests came back positive.
Yes.
Then it was like general quarters.
Oh gosh, it's
So,
horrible.
yeah, it was rough.
Yeah.
It was rough.
Yeah, I think that was, honestly, I think it was to drive the numbers up because, the ticker tapes that would scroll against the, at the bottom of your TV for MSN, which I never watched, but they would always, have the death count. And I really believe, or the number of people testing positive, I really believe that was part of their scheme to drive the pandemic. It
would have been interesting.
Going.
You can't do this retrospectively. It would have been interesting if all we had was PCR testing. Those numbers wouldn't have worked out the same for them.
Right, as opposed to antigen. Yeah.
But if if they had parsed the data between these are PCR tests, these are antigen tests, you would have seen two very different cohorts. But they didn't. If you got a test, it was a test. It was all lumped together, and there were, I don't know what the ratio, but there was a very large volume of antigen tests compared to PCR testing going on. So it kind of negated the PCR. It diluted it all out, in my opinion. We paid attention to that in our facility and completely was borne out on our, I'll call it micro scale, but hundreds and thousands of tests we did over that.
Well, and I think what you said was spot on because nowhere in the history of the world has anybody gotten anything when they're asymptomatic. You know what I mean?
That's bad medicine.
It's bad. I mean, this whole pandemic was based on that.
Yes.
That there was asymptomatic spread.
Yes.
And it was they based it on these two bogus, I think they were case studies or case reviews. I don't know. It wasn't even research. It was ridiculous. And a lot of people, when they were wearing masks outside, I'm like, COVID is so sensitive. Like sunlight kills it, wind kills it. Oh, chlorine kills it. And people were in the pool wearing masks. Oh my gosh. It was just insanity.
I was fortunate once again. I lived in a very rural farming community, and the farmers weren't having any of that, as you can imagine. They were like, "Yeah, we're not doing that."
Those farmers are smart.
And so they were like, "We're not doing that." It was the community I resided in was the day in day out practice was very very different than what some of the larger cities were having to deal with. We could kind of sit back and smile.
Yeah.
Somewhat.
Well, and that was my other beef too, is that everything was under EUA, including this antigen testing that they were doing on people. And I thought, why is this under EUA? Because all you're doing is touching a cotton swab to your nose, right?
Okay, so let's talk about methodology. That was supposed to be a nasopharyngeal swab, which if you know anything about anatomy, that is way, way, way back up in there. That's not inside the nares of the nose.
They're trying to touch your brain.
Yeah, people called it a brain biopsy. It's like, what are you trying to biopsy my brain?
Oh,
pretty close.
Horrible.
Pretty close if it's done properly. As time went on, people figured that out, and the methodology was very inconsistent. So it was the validity of the test became 100% dependent upon who took the sample. Did they do it properly at the end of the day? What was happening in a lot of places where because you didn't want to upset your patients, you didn't want to affect patient satisfaction, so you don't do the brain biopsy, so to speak. Parenthetically, it's not a brain biopsy, but people thought that. That skewed data like crazy as well.
Well, I have my own thoughts about that as well, because I did do some research on it, and I found that they sterilized these cotton swabs with ethylene oxide. And if the ethylene oxide doesn't have enough airtime and you're sticking that all the way up towards the brain, it's cancerous in any form to humans. So there's that. But it was more of the premise at the beginning for me when you want me to, so you want me to get vaccinated. And if I don't get vaccinated, you want me to wear a mask and get tested every week. Well, why am I wearing a mask and getting tested every week if I'm asymptomatic? If I'm symptomatic, let's just do what the common sense thing is, and I'll stay home for 5 days, Well,
here's the other thing that got totally skipped. For viral vaccines, I said I was in the military, so there are certain vaccines that have unknown periodicity to them. And the way that we would sort out whether or not you needed a booster, some people do, some people don't, you would check titers. It's very simple to do. And if your titers were above a certain threshold and you were good to go, if it had dropped down, then a booster was recommended for that particular thing. That's not new science. That's gone on forever and ever. Amen. When they were like, you must take the vaccine. Well, I beg to differ because we know that we've been exposed to this in the emergency room now for months. We've been micro-inoculated over and over, so we have been
Natural
vaccinated with
immunity.
the live virus. How about we do titers and see where everybody is? Doesn't matter what your titer is. You must take the vaccine. So that immediately became a red flag.
Who was saying that to you? The hospital administrators?
No, that was what was coming out of NIH and CDC.
Right.
Because it wasn't just me. I mean, medical professor, everyone was like, why don't we check? For those of us that have been exposed and we know long before it was named, why don't we see what our titers are? Because chances are we have mega titers and we don't need anything else.
Exactly.
We're as vaccinated as we can be.
You will never need anything.
I mean, we're as vaccinated as we can be.
Yeah.
Oh, no. No, this is different. Everyone must take the vaccine. So that was a red flag. Should have been a red flag to everybody. In my particular facility, we finally got the ability to do titers. We got the reagents and stuff. We started doing them. Well, to validate the test, you have to run X number of them. So they go around and ask people to volunteer to give samples. So I was like, sign me up. So basically, we took everybody that worked in the ER that was willing to do it. Well, guess what? Everybody in the emergency room had titers off. I mean, say that maximum titer number was 100,000. I don't know what it was.
Right.
Well, ours would all hit that, and then it stops counting because your titer so high, it just says over.
Right.
So 100% of us had titers
Unbelievable.
out the roof. And so when it came time for vaccines, like, we don't need them. Here's but the corporation says you do. I don't care. This is science has held forever, and I'm not going to be held up by a corporate policy that's pandering to anybody or anything. It makes no sense.
No.
So
absolutely.
But they still didn't care. They were like, well, it doesn't matter because NHCDC says that doesn't matter in this case. Well, why is it different? Why is it different in this case?
Yes.
It's not.
Right. Where's the research for that?
Right.
Exactly.
There was none.
Yeah, it was all political and money ties. Well, and this is what happened to me when I was working as a professor at this military college. Basically, I said, look, I have natural immunity. What they said was, well, you won't be required to get a shot for 3 months. That natural immunity would only last me for 3 months. That's how, it was just ridiculous. And I remember having a conversation with somebody and saying, look, if I have natural immunity, I don't need nothing now. It's better.
Right.
This is better than anything that I could ever get.
Ergo chickenpox. There was a time where when kids got chickenpox, you found out that Johnny had chickenpox, you're like, hey, I'm bringing Billy Bob and Joe Suey over.
We're having a party.
Because once you had them and you were done.
Yes. And better to have them when you're young. Yeah,
that's acquired immunity.
Exactly.
Right? And it sticks.
Yeah.
Yeah, a lot of those arguments didn't wash with what we knew, but they didn't fit the narrative of the time either. So everything was counter to that, to what we knew.
Well, I just have to say that I really wish I was living in your small town during COVID. I really wish I knew you during COVID because you did everything right. You really did. I know you didn't do everything perfectly, but you...
We were trying to do the best we could based on what the information we had.
Well, and so this is the thing is you didn't leave behind your training. You said, okay, this is something new. We have to rely on evidence-based information.
Wasn't new. Let me just thought it wasn't new. It was a coronavirus.
Right.
It was a manipulated coronavirus, but it wasn't like, oh, this is a new virus no one's ever heard of.
Right.
We knew what the virus was. It was a strain, a
chimerically
engineered strain of a known virus. So the question was, what have they inserted into the DNA, if you will, the RNA of this thing? What have they inserted? And it's probably still being unraveled, to be fair, because of the whole engineering that can go into these types of viruses. But so it wasn't that we're dealing with something new, which was even more perplexing that it was being treated like that. It's not like when smallpox was discovered.
Oh, right.
I mean, to use a vernacular, well, when smallpox was discovered a bazillion years ago, they was like, oh my gosh, we got to get this under control. All hands, all hands, all hands. It wasn't like that. It wasn't a new something. It was a variant of a something that had pretty high virility. There's no doubt about it. I mean, the virility of the thing was potent.
Yes.
which thank goodness has died off, which viruses do over time. I mean, we
Yes.
still have people that come up SARS-CoV-2 positive. They just aren't sick from it per se. They have a cold, go on. It's the new common cold, as we say. But it was engineered to be highly viral, which is what you do with, in my opinion, bioweapons.
Yeah. Yeah, it was. It's a biological weapon. Yeah. It is. It's no question.
I also don't believe that was intended to be released on the world per se. I think that it was an accidental loss of containment, and then we had to deal with it. But it was definitely had high virility to it when it came out.
People capitalized on it.
Yeah, and then people lost their minds, as I say.
Totally.
Yeah.
Well, and so that's what I'm saying is that there was an element to this that was new territory, and the virus had mutated, which we know it wasn't mutated.
And it will continue to.
Yeah, but that you had something that was, like you said, very severe. You had lots of powers pushing down on you to do certain things, but you stuck to your guns and you went back to the basics and said, what do we know? What has worked in the past?
Yeah, science worked for us. I mean, it clearly empirically worked for us.
Valid and reliable.
So I can look in that rear view mirror and not have any regrets or nightmares or woulda, shoulda, couldas. Not say we did everything perfect. There's no perfect this side of heaven. But we were trying to do things as right as we knew based on the information we had. And we would adjust sometimes daily. I mean, if information came out and it was evolving that quickly, we would adjust what we were doing. But those were minor adjustments, course adjustments. They weren't like major steers, turning hard left, turn hard right once we got going. And so we saw what I feel like were good successes.
Yeah, absolutely. Yeah, you are a microcosm.
Everybody walked out.
Yes.
So that's
and
win.
5 days later, do you know how long my husband stayed in the hospital?
Oh. There's no telling.
He was in the hospital 18 days because I couldn't get him out. It was terrible. It was awful.
They were trying to get him on a ventilator.
Oh, absolutely. 100%. Yeah, 100%. Is there anything that you want to add? Anything you want to tell people?
A couple of phrases I use commonly. This is going to sound very repetitive. Common things are common. Common things are common. Dust starts getting stirred up. Look for the common thing first. Use common sense.
Yeah.
Goes a long, long way. And if somebody says something to you and it makes you cock your head to the side and you go, that doesn't sound right.
Yeah. Listen to
probably
your gut.
Want to back up a couple of steps and figure out why that doesn't sound right to you. I mean, it probably isn't.
Well, and here's the other thing. You strike me as a physician that if you said to me, take this drug for this issue, I would look at you and I would say, why?
Well, you wouldn't have to, because I'd say, hey, here's what I'm going to recommend we do, and this is the reason why.
Exactly. Thank you.
And so I try to assuage all those, and I do not mean this in the diminutive. The uneducated questions that come in, I don't mean that badly. It's just like, I get paid to do my job for a reason. I have a lot of education for it, and I need to be able to articulate that to a person who doesn't have the same background in a way that's easily understandable and to try to assuage fear.
Right.
Listen, the other thing that COVID did, in my opinion, is any distrust that was ever had for the medical profession was amplified 1,000 times across the board, and it caught all of us.
Absolutely, yeah.
Because then it was like, well, you can't trust anybody. I mean, what do you trust? All of a sudden, this person says this person says, I am science, and I am the expert. We
all know who that is.
And I am the expert, and he's saying this, and then you got this country family practice doctor over here going, no, that's not right.
Yeah.
So who are you supposed to believe?
Right. Yes. And that is a tragedy.
It overcomplicated the situation.
Right. Because now, like you said, people aren't going to trust anybody. And I come to you because I know that you have got all this training, that you have an evidence-based practice. This is why I come to you. This is why I'm paying you to treat me, is because I don't have your mind. And this is what I need is your mind. And I need you to tell me, hey, these are your choices. This is why I think you should go this way.
I think it's still important, though. I will say this, I'm an osteopathic physician by training, so the philosophy's a little different than allopathic training is, but not a lot anymore. It used to be historically very different. I just come from a background that's like just explain everything as easy to understand as it can be, and then people are like, okay, I get that. I get it, and they'll be compliant, for lack of a better word. There's so much non-compliance in medicine. And a lot of it's because things get thrown at people.
Yes.
And then they go home and look at this stuff, and then they'll Dr. Google it, which is not good. And
yeah.
Anybody knows you can go on the internet and find anything to support any position on anything. And
Absolutely.
so they, unfortunately, if the first thing they open is a negative review of this, then by golly, that's it. And I'm not doing that. I try to get past all of that. I mean, I have a very few minutes, and I try to answer questions and make sure people understand before they leave me. This is what we're doing, and this is why we're doing it. You on board with that? You have any questions at all? I think that we have pretty good success with that approach for the majority of folks.
That's rung true for me as a physical therapist. They come to me and I ask them to do things when they're away from me. I know that if they don't do those things, my treatment is not going to work for them.
Correct.
And so I have to educate them and say, this is why I'm asking you to do this. There is a reason why, and it makes a lot of sense if I just explain it to you. Then they're going to be more compliant almost 90% of the time.
It's all about compliance.
Absolutely. Just making people... And
compliance is about understanding.
You tell me something and I go, I don't know. You're going to have to sell me on that. And then you talk to me about it and I go, oh, okay, that makes sense. Now you've won me over. Right. Sure, I'm going to do that.
Sure.
Yeah, absolutely. And here's the other thing that I think when I look back on your story, that I really see the God's hand where he was guiding you. Because for you to find the FLCCC so quickly in the scheme of things, those things and your mind of being independent and that I know what I'm doing. I practice medicine for, and these things always, like you said, are common. These things remain true, that I really feel like the Holy Spirit was really guiding you in a certain direction, and you were listening to that. But I see God, divine interventions that were happening throughout.
No
this
doubt
whole
about
thing.
it. We said that on a daily basis, that we're looking for divine interventions here because we don't know what we don't know. So we're looking for divine intervention and trying to do the best we can. There's no doubt, and I haven't said that up till now, but there's no doubt that God's providence was on the path that we were on for people to get up and walk out of the hospital. And
absolutely.
I don't believe that was just for COVID. I believe that's medicine in general. I think that's
Sure.
my mission.
Yes.
My mission every day. There's a quote from Voltaire that said, the physician's job is not to heal people. It's to hold their hand, entertain them, make them laugh until God heals them. I believe that was Voltaire. I'm pretty sure Voltaire said that.
That's
so
awesome.
If somebody goes and finds that and goes, oh, you got the quote wrong. Okay, fine. I got it wrong.
The quote stands.
The quote stands.
Yes.
I'm pretty sure it was Voltaire that said it.
Yeah.
We don't heal people. God heals people.
Mm-hmm.
We provide guidance, if you will, and informed information and within the bounds of what we know. And then the rest is, and not to be cliche, the rest is truly up to God.
Mm-hmm. Yeah. It's very evident that his fingerprints were on this entire season, I think for both of us in many different ways. But I have to say, it's been a pleasure to hear your story. And I'm so grateful that you decided to talk to me. And because I know there are a lot of other healthcare workers out there that have different stories and some that do have similar stories, but just haven't told them. And I think a lot more people need to tell them, because I've heard of some really endearing stories where people were nightingales and they were very heroic in that they took chances of being fired in order to do the right thing for people. God wanted them still in that position because he knew that they could do more good there than if they weren't there.
Absolutely.
So anyway.
Absolutely.
Well, thank you so much for spending time with us.
You're most welcome. Thank you for the opportunity.
Maybe we'll do a part 2 interview next year.
Maybe so.
Thank you, Doctor. I appreciate
you so much.
it.
Have a good day.
And now we come to it. So what? So what, Dr. Toe? This story needs to be heard by people around the world. Why? Because this story is the nail in the coffin and a solid confirmation that the way COVID was handled by governments, health agencies, hospitals, and healthcare workers around the world was a 100% complete failure. We must never give away our financial freedoms ever again. And we were right. Natural immunity is king. And there's no such thing as asymptomatic spread of a virus. Early treatment, supplements, ivermectin, HCQ, steroids, and antibiotics were the simple answer that would have allowed close to 100% recovery. This interview leaves all those who remained complacent and compliant without excuse. You should have done the right thing, even if it meant losing your job, your career, your livelihood. Some did, and they paid the price, but they did the right thing. But one thing is clear: had the majority of healthcare workers and hospitals done the right thing, COVID would have been a different story with a different outcome. There's no question. Late treatment, remdesivir, ventilators, antigen and PCR testing, masks, jabs, and social distancing were all bad medicine, and in some cases, death sentences. A retroactive meta-analysis study needs to be done comparing this hospital to other hospitals during COVID. But the question remains, who will be brave enough to do it? Well, that's a wrap. If you like what you heard, please like and share. Want to hear more? Please subscribe. And if you're a faithful listener, thank you for all your love and support, because without you, I would not be here. I'm glad you're along on this journey with me. We have each other, and we are not alone. Pursue health, live free, and breathe deep. Until next time, everyone, this is Dr. Toe, signing off. Important disclaimer. This podcast is presented solely for educational and entertainment purposes. I am not a medical doctor, and I do not diagnose, advise, or treat. This podcast is not intended for the substitute of advice from a personal physician, professional coach, psychotherapist, or other qualified professional. It is not intended to be used or relied upon for any diagnostic or treatment purposes, or to be used as a substitute for professional diagnosis, treatment, or conventional medical therapy. None of the statements made in this podcast have been evaluated by the Food and Drug Administration. Please consult your healthcare provider before making any healthcare decisions or for guidance about specific medical conditions. Listen responsibly.